Hello, everybody. It's Ryan here, board certified specialist physician. This is our 53rd episode in practical internal medicine. I hope you guys are well. And we're talking about vaginal bleeding with the focus on the patient being non pregnant. Okay. Now, just a disclaimer, guys, I'm not a gynecologist. I'm not an obstetrician. I'm just a physician who loves internal medicine. And our patients don't read textbooks, right? So sometimes we can end up seeing patients who do have vaginal bleeding, especially in the context of working up anemia. Okay, so it's important for us to consider an approach to vaginal bleeding, right? If you haven't yet subscribed to my channel, I encourage you to think about that. I really appreciate your friendship on my channel. Today's our fourth dad joke, guys. So, my friend says I'm getting fat. Okay? Yeah. But in my defense, I've had a lot on my plate recently. Okay, guys, when we look at abnormal genital bleeding, okay, we're focusing on the non-pregnant females, okay? So by and large, the first stratification point, guys, is it gynecological or non-gynecological? So if it's non-gynecological, then you expect some parameters on your laboratory workup to be abnormal. Like if you got abnormal INR, abnormal PT, abnormal platelet count, okay, is there liver disease? I mean, liver disease causes coagulopathy on many accounts, right? First up, we say that there's diminished bile, and bile emulsifies fats, and vitamin K, which is used to synthesize our coagulation factors, is fat soluble. That's the first thing. And the second thing is if the liver is failing, it can't produce the clotting factors itself. Okay. And the vitamin K dependent factors, you guys remember, is 2, 7, 9, and 10. 2, 7, 9, and 10. But think about the year 1972, but just replace, or just add a zero in there so it becomes 10, 9, 7, and 2. Guys, how does chronic kidney disease cause bleeding issues? Well, it causes qualitative platelet dysfunction. Okay. Even though the platelets may be normal in number, they're abnormal in function. Okay. And drugs as well. Drugs can obviously cause bleeding issues. But if it's a gynecological issue, we can further divide it depending on the anatomical structure that's responsible, right? So is it the uterus? Is it the cervix? Is it the vagina? Is it the vulva? So prudent to get a pelvic ultrasound, okay? And there you might find, okay, there might be atrophy, there might be fibroids. Fibroids, very, very common cause of uh, vaginal bleeding. Okay, there could be a polyp. The patient could be taking exogenous estrogen. It could be something more sinister like a neoplasm. It could be simply infections or pelvic inflammatory disease and that, or it could be simply endometrial hyperplasia. Cervix, so cervical cancer definitely can cause bleeding. And we'll talk about the different kinds of vaginal bleeding that you get in terms of the history. But cervical bleeding, of course, the lesion could be a polyp, it could be ectropion, dysplasia, neoplasm to cervical cancer is quite common, cervicitis or trauma. In the vagina, we could have vaginal atrophy that usually happens in patients who are hypoestrogenic or older. Vulvovaginitis, it could also be a neoplasm infection trauma. So you see the same kind of theme throughout different structures. Vulva as well, much the same. Okay, so practically now, guys, if the patient comes in with vaginal bleeding, a non-pregnant female vaginal bleeding, there are four main branch points. Okay, is it heavy menstrual bleeding? Number one. Then we talk about menorrhagia, which is very, very heavy bleeds. Is it polymenorrhea being more frequent menses? Or is it metrorrhagia? There's different terms we use. Is it postmenopausal? Is it intermenstrual between menses, or is it postcoital? Okay. So if it's heavy menstrual bleeding, we think structural versus non-structural, right? So if it's non-structural, probably things like coagulopathy, which we spoke about, foreign body, pelvic inflammatory disease. So the patient complains of flank pain, and they have cervical excitation tenderness when you do a vaginal exam. Okay, hypothyroidism, and you work up appropriately. But if you've got a heavy menstrual bleeding, a structural etiology, they're thinking about fibroids, right? Or you're thinking about adenomyosis. Of course, you want to do a pelvic ultrasound to establish that. And if the patient is older or at risk, then you want to obviously evaluate the endometrium as well. So postmenopausal bleeding, guys, you must think about endometrial carcinoma. So do your pelvic ultrasound, do your papilla biopsy. If it's a cervical cancer, obviously you want to do a pap smear. And if the pap smear shows certain features, you may progress through to a Let's loop, okay, which is excision of the transition zone, lower excision of the transition zone, okay? It could be atopic vaginitis, hormone replacement, pelvic radiotherapy, okay? And then, of course, you want to go forth and examine and evaluate your endometrium with a transvaginal ultrasound, with endometrial sampling, with hysteroscopy, with a papilla biopsy. And then, of course, it could be benign or you could have a malignancy, right? If it's intermenstrual bleeding between periods, you also entertain the diagnosis. Look, this could be endometrial carcinoma, could be cervical cancer or a lesion there. You can also think about hormonal contraception and PID. And there you basically want to evaluate the cervix, right? Pap smear, may want to do a colposcopy with a Let's loop. Okay. And the possibilities is if it's benign or malignant. And if it's malignant, you're going to go forth and do your staging, so probably a CT scan. If it's benign, it could be a polyp, ectopia, or cervicitis. Otherwise, postcoital bleeding is very suggestive of cervical cancer. Okay. Okay, my friends. Now let's talk about Hebrews chapter 8. Hebrews chapter 8 is a beautiful chapter that introduces the new covenant. You know, when Jesus was sharing the communion with his disciples at the Last Supper, he said, take, drink. This is the new covenant in my blood. Now, we have to take the words of Jesus seriously. If Jesus said it, it has to be important. And I find that most people don't understand the difference between the old and the new covenant. It's very important. Jesus has come to establish the new covenant. He is the mediator of a new and better covenant. And there's no doubt that the new covenant is far superior to the old covenant. So says Hebrews chapter 8, verse 6. It says, the ministry Jesus has received is as superior to theirs as the new covenant of which he is a mediator is superior to the old one. Why? Because the new covenant is established on better promises. So in the Old Testament, we can see Moses went up to the mountain to receive the Ten Commandments. In the new covenant, Jesus went up to the mountain and was crucified and gave us the Holy Spirit. Okay? Now, in fact, in the book of Hebrews, it is mentioned 13 times that the new covenant is superior or better than the old covenant. Okay? So, in the next few videos, we'll be covering medical topics, but we'll also be covering what the new covenant is and why it is so important for us to understand it. Now, remember that the New Testament is different from the new covenant. Covenant simply means agreement. It comes from the Hebrew word meaning berith, which means agreement. But testament just refers to a collection of books. Okay? And we'll talk more about this in days to come. God bless you. Here are my references. Take care.